Distinguished ladies and gentlemen, the academic procession will have to file in on time today because the outside is getting drizzly. It's about to rain. So I want to please crave your indulgence to please find a place for yourself. Make yourself comfortable. We need to move fast. Ushers, please help us in this. Help us, because any moment from now, the academic procession will file in. The moment I get the signal, I will require us to please rise. So please wait. Please shall we now rise for the academic procession. Thank you very much.
Deputy Vice Chancellor, Administration, the Registrar, the University Librarian, Provost of the College of Medicine, Provost of the Postgraduate College, the Dean of the Faculty of Clinical Sciences, Deans of other faculties and of students, Directors of institutes and centers, Heads of departments, the 12th Vice Chancellor of this university, Vice Chancellors of other universities, distinguished guests, ladies and gentlemen. The 564th University of Ibadan Inaugural Lecture will be delivered this evening by Professor A.A Adenipekun of the Department of Radiation Oncology on behalf of the Faculty of Clinical Sciences, 1966 to 1967. His father, being a civil servant, was on transfer at various times. He therefore continued his primary education at St. Martha's Primary School, Akure, between 1968 and 1969, and completed same at Emmanuel Primary School, Ado-Ekiti, to 1971. He attended Christ School at Ado-Ekiti between 1972 and 1978, and he also had his higher school certificate from the same school. He gained admission to the University of Ibadan in 1979 and graduated in 1984 with Bachelors of Medicine, Bachelors of Surgery, MBBS. He enjoyed Cocoa Board scholarship while in the medical school. He concluded his residency program in radiotherapy and obtained the fellowship of the National Postgraduate Medical College in 1994 and fellow of the West African College of Surgeons in the year 2000. Professor Adenipekun received additional training at Tata Memorial Hospital, Bombay in India in 1994 and at Advanced Medical College, Moscow, Russia in 1990, all sponsored by the International Atomic Energy Agency, during which he also obtained certificates in radiotherapy and nuclear medicine. Professor Adenipekun has received several grants, awards, and fellowships, some of which are the University of Ibadan Senate Research Grant in 1998 to study the effect of doxorubicin chemotherapy on hearts of breast cancer patients. International Union of Campaign Against Cancer, Cancer Awards to study stereotactic radiotherapy in brain metastasis at the University of California, UCLA in the United States in 1998. International Atomic Energy Agency Fellowship on Breast Conservative Management in Morocco in 1999. Training in palliative care at Uganda, sponsored by the College of Medicine of the University of Ibadan in 2005. International Atomic Energy Agency Fellowship training on high dose of rate brachytherapy in Bayreuth, Germany in 2006. Professor Adenipekun joined the services of the University of Ibadan as lecturer grade 1 and consultant radiotherapist in the Department of Radiology and also at the University College Hospital in 1995. He rose through the ranks to become senior lecturer in 1998, reader in 2007, and professor in 2014. Professor Adenipekun obtained the Doctor of Medicine at the National Postgraduate Medical College in 2020. He is presently the Chief Examiner in Radiation Oncology at the Faculty of Radiation at the National Postgraduate Medical College for over 5 years. He has served the University of Ibadan in various capacities, such as acting head of department and head of the Department of Radiation Oncology, College of Medicine at different times. He was a member of panel of disciplinary committee and Senate representative at the Students' Lodging Board. His works on palliative care brought about the establishment of the hospice and palliative care department at the College of Medicine, University of Ibadan. He was secretary of the Medical and Dental Consultants Association of Nigeria, MD-CAN, UCH. Vice Chairman, MD-CAN, UCH. The Chairman, MD-CAN, UCH, between 1998 and 2005. He was appointed Chairman of the Medical Advisory Committee, CMAC, of the University College Hospital between 2006 and 2010. Outside the University of Ibadan, Professor Adenipekun has served as examiner for master's and PhD programs. He was past president of the Hospice and Palliative Care Association of Nigeria, vice president of the Center for Palliative Care Nigeria, member National Nigerian Institute of Management, charter member National Association of Artificial Intelligence Practitioners. He has also served as assessor for candidates being considered for professorial cadre at the University of Nigeria, at the universities in Nigeria, and also at the University of Cape Coast in Ghana. Professor Adenipekun is widely traveled and has attended many local and international conferences and has presented quality papers. He has over 60 academic publications to his credit in peer-reviewed journals, including a chapter in a book on palliative care. Professor Adenipekun is a devout Christian, a zonal pastor at the Redeemed Christian Church of God RCCG Jesus House, Bashorun, Ibadan. He is also the chairman of the Central Head Board of the Redeemed Christian Church of God Mission. Professor Adenipekun is happily married to his lovely wife, Clementina Onyikonsola Adenipekun, a professor of botany here at the University of Ibadan, and they are blessed with 4 lovely children. Distinguished ladies and gentlemen, I now invite Professor Adeniyi Adenipekun to present his lecture, which is titled Dealing with Rebellion in the Commonwealth of Cells with Guided Missiles, that the obedient may live. Professor Adenipekun.
The Vice Chancellor, Deputy Vice Chancellor Administration, Deputy Vice Chancellor Academic, Registrar, Librarian, Provost of the College of Medicine and Postgraduate College, Dean of the Faculty of Clinical Sciences, Deans of other faculties and of students, Directors of institutes, distinguished ladies and gentlemen. I am grateful to God for the opportunity to give this inaugural lecture on behalf of the Faculty of Clinical Sciences of our great university. I really want to thank the Almighty God through His only begotten Son, the Lord Jesus Christ, for making this occasion a reality. He deserves all the glory. My tribute goes to Professor O.B. Campbell, my teacher, who delivered the first inaugural lecture in 2016 from a department, making me the second. However, today I stand as the first alumnus of this university from the Department of Radiation Oncology to deliver inaugural lecture on behalf of the Faculty of Clinical Sciences. The title of the inaugural lecture delivered by Professor Campbell was Breaking the Yoke of Cancer. The Department of Radiotherapy started in the year 1987 as a unit of the Department of Radiology. In 1992, it became a Department University College Hospital, but remained a unit in the university until 2005, when it was granted full departmental status in the College of Medicine by the Senate of our great university. The department had a change of name from radiotherapy to radiation oncology. This was approved by the university in 2015 in order to align with international nomenclature in cancer management. Over the years, the department has grown in leaps and bounds in training medical students and allied health professionals and cancer research. Through our postgraduate and residency training programs, The department has produced many radiation oncologists and psycho-oncologists for most of the cancer centers across Nigeria and beyond. To date, the department is the only one with MSc program in psycho-oncology in sub-Saharan Africa. This subspecialty is very important in supporting cancer patients with psychosocial needs towards improving their experience throughout their cancer care journey. Mr. Vice Chancellor, sir, permit me to describe my sojourn in the field of medicine and radiation oncology. Over 40 years ago, as a young boy, I gained admission to read veterinary medicine in this great university in the prelim class. My primary interest was in medicine because of my contact with a doctor, Dr. Berega, while I was in primary 4 at St. Matthias Primary School at Akure. Dr. Berega was a well-dressed, smart doctor who, unknown to him, sparked up my interest in medicine. After prelim, I was able to cross to medicine, courtesy of the foundation provost of the College of Medicine. And I was privileged to be tutored by the eminent professors and teachers, including the likes of Professor Adetuyibi, Dr. Alabi, a.k.a. Common Things Occur Commonly, Professor Luri, Professor Ladipo. They all provided the academic stimulus that prompted my resolve to return to this great university to teach medical students. Mr. Vice Chancellor, sir, it was fate that brought me to radiation oncology, as there was no such specialty during my days in the medical school. In 1989, while working as a medical officer with Oyo State government, a friend and an old classmate of mine, Dr. Asako Ishegun, the only resident in radiotherapy at University College Hospital Ibadan, invited me to his unit to stand in for him as a locum doctor because he was proceeding on leave. He introduced me to Professor S.B. Lagundori of blessed memory, who encouraged me to take my annual leave from the primary assignment in Oyo State in order to pick up this locum appointment. It was during this 1 month locum that I developed interest in the specialty. I had to resign from Oyo State appointment to pick up this residency training in radiotherapy at UCH Ibadan. At this point, I want to specially thank Dr. Ishegun, late Professor Lagundori, and Professor Campbell, whom God used as my destiny helpers during this period. May God bless all of them. Mr. Vice Chancellor, sir, cancer management is a wide subject, but I shall be talking on the safe use of ionizing radiation to treat cancer because it is the focus of my work as a clinician, a clinical teacher, and a researcher. What we call cancer is formed from a group of cells in the human body that have developed the ability to ignore routine organizational directives that make the cells in the human body to work in sync and rhythm like an organized system, with each other cells handling their own specific jobs without interfering with other cells other than as required for bodily functions to be performed. The cancer cells can be likened to a group of citizens or non-citizens of a country that have rebelled against the authority of the country or territory and are determined to completely occupy the country by displacing everyone else. In normal parlance, we will refer to this group of people as rebels or terrorists. In a sense, cancer cells are terror to the human body system as they attack and destroy the harmonious working of the body cells. Cancer dehumanizes the human body, it becomes uninvited, spread its influences and control to the host body, ignoring all the control mechanisms of the body system with the aim of destroying the host. Cancer cells are a major problem to the rest of the body, not involved in the cancer process. The rest of the cells continue to obey the body regulatory system and perform their expected functions. These obedient cells are crucial to the ability of the human body to survive invasion by these cancer cells. Mr. Vice Chancellor, sir, I would like to take a little time to describe the Commonwealth of cells, the development of the rebellious and disease group, how my work helps to minimize and eliminate these rebellious cells so that the obedient ones may survive. The Commonwealth of cells. The human body is composed of trillions of cells, which are the basic structure and functional units of life. I would like to give a brief overview of the cellular system, not to turn you all into cell biologists, but to give you the required basic understanding of the system to make it easier for you to understand the basis of this lecture. Cell structure. A typical cell has a well-defined structure that helps it to maintain form and perform its function. The cell membrane is the cell outside, the cell membrane is the cell's outer covering. and is also a lipid layer that controls the movement of substances in and out of cell. The cell contains a nucleus which contains the cell genetic material, the DNA, and controls the cellular activities. The cytoplasm is a gel-like substance within the cell membrane containing organelles such as mitochondria, which is for energy production, endoplasmic reticulum for protein and lipid synthesis, and Golgi apparatus modifying and packaging proteins. Types and functions of cells. The cells are the building block of the human body, each with specific role that contributes to maintaining homeostasis and overall health. Each cell type performs different roles in maintaining the proper functioning of the human body. For instance, the epithelial cells perform protective, secretory, absorption roles for the body. As lining of the body surfaces, they regulate what the body absorbs and what it sends out, and regulate what can get into our system. The muscle cells perform movement roles, moving food through our digestive system or blood through our circulatory system, the smooth muscles, helping us to move about, the skeletal muscles, helping us to pump blood into and out of our heart, the cardiac muscles. The blood cells perform defense functions, that is the white blood cells, help move oxygen around our body, the red blood cells, help repair damage and prevent blood from draining from our body, the platelets. The nerve cells help send signals around our body, directing the affairs of other cells, while the stem cells form a pool of uncommitted cells that can transform into other cells as required by the body. They are body reserve steam, ready to replace other cells when the need arises. The rise of rebellious cells. Mr. Vice Chancellor, sir, the rebellious cells is a term that can be used to describe cells that exhibit behavior that is different from the normal, regulated process of cell growth and division. The term can be applied to cancer cells as they are prime example of cells that defy the typical controls of cellular behavior. The breakdown of what makes these cells rebellious and the characteristics that define them are as follows. 1, uncontrolled growth. Unlike normal cells, which grow and divide in a controlled manner, the rebellious cells proliferate uncontrollably. Evasion of apoptosis. Normal cells undergo a process called apoptosis, that is programmed cell death. When they are damaged or no longer needed, cancer cells often gain the ability to evade this process, which allows them to survive despite being abnormal or dysfunction. Genetic mutations. Cancer cells frequently have genetic mutations that alter their behavior. This mutation can affect the genes that are involved in cell cycle regulation, invasion, and metastasis. Rebellious cells often acquire the ability to invade surrounding tissue and spread to other parts of the body without any restriction. Immune invasion. Cancer cells can develop mechanisms to avoid detection and destruction by the immune system. Angiogenesis. To support their rapid growth, cancer cells or rebellious cells can stimulate the formation of new blood vessels to supply the tumor with nutrients and oxygen. Alter cell signaling. Cancer cells often have alter cell signaling pathway that deregulate the balance of cell growth and death. Genomic instability. The rebellious cells tend to have a high degree of genomic instability. That is, they frequently accumulate genetic changes. This instability can further drive their aberrant behavior and contribute to their malignancy. Rebellious cells, particularly cancer cells, are characterized by their disregard for normal cellular control mechanism. They grow uncontrollably, evade death, invade other tissues, which are driven by genetic mutation and cause alterations in signaling pathways. Mr. Vice Chancellor, sir, what is cancer? The characteristics of rebellious cells described above are the basis of cancer formation. So what is cancer? The American National Cancer Institute simply defines cancer as a disease in which abnormal cells divide uncontrollably and spread to other parts of the body. This spread can be achieved through the blood vessels, the lymphatic channels, or by direct spread through tissue planes. The word cancer. Cancer is a Greek word for crab. The original word was carcinus, which was adopted into English language as canker. Canker continued to be used until the 17th century when it transformed into cancer. Crab as a name was adopted because of the finger-like pattern of cancer spread, resembling the shape of a crab. Radiation oncology. This is the study of medical application of ionizing radiation in the management of malignant or sometimes benign tumors. The physician trained at the postgraduate level in the heart of medical use of ionizing radiation for cancer management is referred to as radiation oncologist. The use of ionizing radiation in the treatment of cancer patients started in 1896 when a lamp manufacturer in Chicago named Emil Hermann Grob teamed up with a physician friend to treat a patient with X-rays. Grob had been working on X-rays after reading the work of Wilhelm Röntgen, who had discovered X-rays a year earlier. As a follow-up to the work of Röntgen, Henri Becquerel discovered radioactivity in 1896. And in 1898, Marie and Pierre Curie, they were actually a couple, discovered two radioactive elements, which they named polonium and radium. This discovery led to rapid progress in the use of radiation to treat cancer. The first recorded cancer care using X-ray was documented in Stockholm in 1899 when Dr. Torsten Steinberg treated a woman with basal cell carcinoma of the nose. The early history of radiotherapy in Nigeria dates to the mid-20th century. The first radiotherapy facility in Nigeria was established at a general hospital in Lagos by a dermatologist using an autovoltage machine to treat skin diseases. This was followed by Lagos Teaching Hospital in 1975 and later University College Hospital Ibadan 1980. Radioactivity is the process by which unstable atoms achieve stability by undergoing intranuclear reactions with emissions of nuclear radiation. These unstable atoms are called radionuclides or radioisotopes, and the emitted radiation include beta particles, electrons, protons, alpha particles, and gamma rays. Radiation produced in this process can be harnessed for treatment of cancer patients. It should be noted that the process described here is the same that happened in nuclear or atomic bomb and in nuclear reactors for power generation. Mr. Vice Chancellor, sir, radiotherapy is a highly targeted and precision medical treatment, not so much different from missiles used in modern warfare. The work of radiation oncologists is not unlike that of a military general plotting the destruction of the opposing camps. It involves identifying targets, using satellite images, geographical coordinates, choosing the right ammunitions, either long range or short range, intercontinental ballistic missile, choosing the mode of delivery, surface to air missile, or using a bomber. And when any cell receives radiation exposure, several things can happen depending on the type of cell, its state, and quantity of radiation dose received. For instance, if the dose is low enough, the cell may survive without any sign of damage. The cell can also sustain a potentially lethal damage when, if given favorable condition, may manifest. Such favorable condition is the oxygenation situation, or the state of the cell in the cell cycle. A cell deprived of oxygen will survive radiation exposure better than cells that are properly oxygenated. This is one of the reasons why we always ensure that our patients have enough blood before they commence radiation treatment. A cell exposed to radiation may sustain sublethal damage. This is a small damage that the cell may be able to repair. However, when further doses are given, what we call fractionation, the accumulated SLD, such that the cells will now be unable to do further repairs and will therefore succumb. Modes of radiation delivery. As a Vice Chancellor, sir, radiotherapy for cancer management is either using two broad methods, teletherapy distance or brachytherapy short distance. Teletherapy, which can be described as a long-distance therapy, is when the source of radiation is relatively far from the part of the body being treated. It is also described as external beam radiotherapy, EBRT, because the source of radiation is external to the part of the body being treated. EBRT is achieved either using radioactive cobalt-60 machine or a linear accelerator. In cobalt-60 machine, the source of radiation is a radioactive element called cobalt-60, which continuously decays and emits gamma rays that are used for cancer treatment. The radioactive source is housed in a highly shielded head called gantry, remotely to be delivered as desired. Accelerators units are also used to deliver EBRT. Accelerators can be straight, which we call the linear accelerator, or have other shapes like cyclotrons or decatron. The accelerators like an atomic particle, such as electron, proton, neutron, and speed them up with high voltage to high speed and high energy, suitable for desired energy treatment. The regular linac can produce accelerated electrons, X-rays, brachytherapy. The radiation source is either internally to the part of the body being treated or very close to it. It involves inserting radiation source through appropriate treatment applicators into the body parts directly or into the body lumen or cavity. Radionuclides used in brachytherapy can be in form of seeds, wires, or needles, like cesium-132, 137, cobalt-60, iridium-192, iodine-125, and some of the common radionuclides used in brachytherapy. Prostate and cervical cancer are the two common cancers treated with brachytherapy at University College Hospital, Ibadan. Brachytherapy can be also classified traditionally into either low-dose rate, medium-dose rate, or high-dose rate. The modern brachytherapy practice is safe for both patients and radiation oncologists because the source is remotely controlled. Mr. Vice Chancellor, sir, my accounts of research, teaching, and service to the community. Mr. Vice Chancellor, sir, my research will focus on innovative radiotherapy, pediatric radiotherapy, palliative care for advanced cancer patients. The main objective being towards solving problems encountered in the treatment of numerous patients living with cancer with limited facilities and yet without compromising on effectiveness and safety. At the time around 90s, our center was the only functional radiotherapy center in Nigeria and was able to effectively manage patients from entire West African countries as far as the Gambia. Pediatric radiotherapy. Since the children are not spared from having cancers, we were and still having many children referred to us for being radiotherapy. For safe delivery of radiation to the appropriate site, these patients have to be immobilized, and to achieve this, we must sedate the patients. The sedation was necessary to ensure that patients maintain same position during treatment. Otherwise, a little shift may result in radiation to the wrong site. Patients stay alone in the treatment room during the treatment and being supervised, unsupervised, except 2007, where the pattern of pediatric patients seen at the department, majority were found to be living with retinoblastoma, a malignant blastoma, a malignancy of the eyes, but unfortunately, majority of them were presenting at late stages. Breast cancer radiotherapy. Mr. Vice Chancellor, sir, breast cancer incidence among women is high and rising. Breast constitutes about 25-30% of all cancers seen in Nigeria. In our facility, we used to have a large population of patients living with breast cancer waiting for treatment, being the only functioning machine in the country then. The treatment procedure employed then was usually extensive, laborious, ensuring coverage of radiation to the chest wall, armpit, supraclavicular fossa, and the mediastinal lymph nodes of patients after undergoing surgery. The idea then was that this treatment procedure of extensive radiation fields should improve local control to some extent. However, this procedure kept patients for weeks on radiation treatment, thereby reducing the number of patients that could be attended to, and invariably led to long waiting time for patients to have access to radiotherapy. In addition, some side effects were observed, particularly lymphedema, which is so troublesome and difficult to heal. This was found in a study conducted by our team, reported in literature A.A Adenipekun 2013. These side effects particularly common if radiation treatment is given following axillary clearance at surgery. Following this troubling trend, our team studied the use of clinical judgment, histological reports, available information on the extent of surgery as selection criteria to select our patient that will receive radiation to the chest wall only. Our study showed that patients with early disease and clinically negative axilla perform better with only chest wall irradiation. The degree of local control was comparable with patients who had more extensive radiation. Adenipekun 2002. By this result, we were able to show that more patients can achieve good local disease control from surgery and limited radiotherapy to the chest wall while reducing morbidity, especially the lymphedema of the upper limb that usually occur when armpit is irradiated. This eventually increased the number of patients treated, and timely access to treatment by our patients was greatly improved. To further improve disease control after surgery in our patients, we started the combination of chemotherapy and radiotherapy. This is called chemoradiotherapy. However, this combination, though effective, is also poses its own challenges, including increased side effects and toxicity, depending on the drugs used in the chemoradiation in nasopharyngeal cancers. Furthermore, Adenipekun 2013 reported chemoradiotherapy of squamous cell carcinoma of left conjunctiva in an HIV patient who remained disease-free 10 years post-treatment. A good response was also reported in chemoradiation management of neuroblastoma in a Nigerian child. Adenipekun 2013. In a Nigerian child. Adenipekun 2013. Early in my research journey, I joined a group of my colleagues to study the risk factors of breast cancer in our population. These are mostly epidemiological studies that aim to characterize breast cancer in Nigerian women. There are many epidemiological factors associated with breast cancer. Adebamawo et al. 2003 reported a significant correlation between breast cancer and young women. We also showed that obesity and height were strongly related to incidence of breast cancer among Nigerian women. Adebamawo 2003. BRCA1 and 2, the genetic abnormality demonstrated among breast cancer patients in Nigeria. Fakintel et al. 2005. Breastfeeding and parity epidemiological factors presumed to be protective against breast cancer. Hildi et al. 2008 found among Nigerian women a strong correlation about the protective influence against breast cancer among Nigerian women who practice exclusive breastfeeding. Likewise, Ogundiran et al. 2010 and 2012 reported association of breast cancer with body size and body fat distribution among Nigerian women respectively. Experimental radiotherapy. Mr. Vice Chancellor, sir, there is no medical treatment without possible side effect. While treating with radiation, normal cells and cancer cells are exposed to radiation, while some possible damage to normal cells are also recorded. Careful treatment planning, aided with right equipment, tends to isolate cancer cells and ensuring that they receive maximum radiation exposure while minimizing the exposure of normal cells. However, it is not possible to completely shield all the normal cells. I joined Malomo et al. 2005 to conduct an experimental study to see what intervention can be done to reduce side effects of radiation on nerve cells, especially spinal cord. The effects of dexamethasone and metronidazole and ascorbic acid on the morphological changes induced by gamma rays on the spinal cord of Western rats was studied. A modified morphological change induced by gamma rays was observed in the rats treated with the drugs, thus suggesting some protective potentials to normal cells. This was part of our efforts to ensure that the obedient cells live. Routinely, when spinal cords or brain is being exposed to radiation treatment, dexamethasone as protective agents to the obedient. Exposure of kidneys to radiation can lead to kidney injuries, including acute nephritis. These organs have limited tolerance to radiation dose, which when exceeded can be hazardous. During treatment of structures in the abdomen, these kidneys may receive some level of radiation. In another experiment to study the protective effects of dexamethasone and ascorbic acid on kidneys, I joined Owe et al. 2008 to expose some Western rats to some doses of radiation to provoke radiation nephritis. The group that was fed with dexamethasone and ascorbic acid morphologically exhibited some form of protection on their kidneys, buttressing the anti-inflammatory properties of these drugs. This knowledge is now being applied in clinical setting. In another experiment reported by Adejuwon et al., we demonstrated the protective properties of Tephria occidentalis extract in radiation-induced oxidative stress right of the brain of the rats. The Tephria occidentalis is the same popular ugu vegetable you all know. In a clinical study, you were able to demonstrate that radiation to other parts of the body during radiation treatment were within normal limits, showing that when properly done, radiation is safe for all the patients while they are receiving treatment, cancer patients. Cancer of the cervix and cancer of the prostate are among common cancers in Nigeria. Cancer of the cervix affects the mouth of the womb and is particularly common among women with multiple sexual partners, those who started sexual intercourse at a very younger age, and with those with large number of children. Treatment for cervical cancer involves surgery, radiation therapy, and chemotherapy. Cervical cancer is one area I work on with my colleagues towards improving outcome of our numerous patients. I joined my colleagues at UCH to publish the first paper on the use of high-dose radiotherapy therapy with cobalt-60 in Nigeria. Prior to this time, cesium-137 and iridium were used as radiation source for treatment of cervical cancer using bacterotherapy in the country. We were able to demonstrate that cobalt-60 is a good radioactive source for high-dose bacterotherapy without any deleterious effect in the paper published by Intekim et al. 2010. This was a landmark report that influenced the wide acquisition of cobalt-60 based bacterotherapy equipment in most cancer centers in Nigeria, even by the Federal Ministry of Health. Radiation of the ovary leads to permanent cessation of ovulation, while in low doses may cause temporary delay of ovulation. The technique was used in the past as what they call radiation ovarectomy. My team studied the effect of low-dose preconceptional gamma irradiation on the morphometric assessment of adult female mice and their embryo. We reported delay in conception, but no abnormality in the embryo of the rats, EDAGA 2012. Mr. Vice Chancellor, sir, it was my privilege to lead a team of specialists that worked on the first bacterotherapy for prostate in Nigeria with good success. Prostate bacterotherapy ensures delivery of optimal dose of radiation to the prostate gland, therefore improving outcome. Absalam et al. 2023-2024 reported our success so far, and our center remains the only center providing such service in Nigeria. Pain and palliative care with radiotherapy. Mr. Vice Chancellor, sir, late presentation of patients living with cancer has remained a serious challenge to the practice of radiation oncology in our patients. Over 7% of our patients present in late stages. In a new aspect of palliative care is a new aspect of care in modern, my colleagues and I did some work on attitudes and knowledge of patients with their families. We reported that palliative care was well acceptable to our people irrespective of their culture and belief. The concept of palliative care for patients is to live to the end without pain and suffering. Another major constraint was unavailability of opioids in palliative care. The preferred opioids in cancer management, we therefore consider using weak opioids such as codeine with external beam to manage pains of bone metastasis. This was largely effective as A.A Adenipekun 2002 reported pain relief among 90% of patients managed within 4 weeks of radiotherapy. We also explored the use of chemotherapy and weak opioids to control pain of advanced cancer patients. 60% of our patients that completed 6 cycles of chemotherapy had adequate pain relief. A.A Adenipekun 2012. We continued use of chemotherapy in advanced cases, and we had good results in many instances. Chemotherapy used to manage a young man with advanced gastrointestinal lymphoma complicated with enterocutaneous fistula, that is communication of the intestine with the skin. We achieved a complete response. The fistula closed, and the man eventually had his wedding engagement that was put on hold because of the illness. However, this effective pain management in advanced cancer cannot be sustained without oral morphine, the gold standard pain reliever in palliative care. This necessitated the formation of Society for the Study of Pain with efforts of senior colleagues like Professor Shinyawo, late Professor Amlobrado, all like-minded, joined together to form that society, and later on we formed the Palliative Care Initiative of Nigeria. Again, with the help of like-minded people, we formed the Center for Palliative Care Nigeria, and which again with like-minded people, we formed the I was the second president of that association between 2011 and 2015. I'm glad to inform the audience that these efforts of palliative care development in UCH has resulted in establishment of the first academic department of hospice and palliative care. This was approved recently by the Senate of the Senate of the University of Ibadan. And this again is the first academic department of hospice and palliative care in Nigeria. To get morphine available to our patients was another bottleneck, but kudos must be given to the late Director General of NAFDAC, Professor Dorothy Akunyuli, who listened to the frequent appeals of palliative care leaders like Professor Shinyawo, late Professor Simbo, and my humble self. With the ability of morphine, we embark on training of healthcare workers to improve their prescription practices following findings from our studies. My teaching services. Mr. Vice Chancellor, sir, my teaching involved teaching of medical students, masters of students of psycho-oncology programs, resident doctors of Prof Medical College, and also West African College of Surgeons. I'm presently the chief examiner of radiation oncology for Faculty of Radiology of National Post Medical College. Community service. I was the executive member of Medical and Dental Consultant Association of Nigeria, UCH branch, from secretary to vice chairman to chairman. I had served as Senate representative of the Bureau of Student Lodging. I was a member of Panel J Disciplinary Committee. I was appointed chairman advisory committee of UCH from 2006 to 2010. I was also the chairman of I'm also the presently chairman of the Central Health Board of Health for the Redeemed Christian Church of God Mission. Mr. Vice Chancellor, sir, the challenges of managing cancer patients are still very much with us. These include late presentation, inadequate funding of healthcare, inadequate treatment facilities, dearth of health professionals, cost of diagnosis, cost of drugs. There are some targeted drugs which are normally required but very expensive. Even senior civil servants cannot afford them without support from government. I must thank the federal government for establishing Cancer Aid Fund and chemotherapy access program, through which at least some patients are having access. Concluding remarks and recommendations. Mr. Vice Chancellor, sir, I have in the last couple of minutes tried to discuss the radiotherapy management of cancer patients using innovative methods, experimental findings in the face of limited resources, and the use of palliative care to eliminate pain and suffering in the advanced cases so that the obedient cells may live. The road to survival of the obedient cell is still very rough, to some that eventually survive. I'm happy to tell you that survivors do put smiles on our faces, and their numbers are actually increasing. My recommendations. Number one, the University Health Center should be equipped to conduct annual screening for all staff of the university to promote early detection of rebellious cells which can potentially lead to cure. Number two, the university should collaborate with the Children's Hospital to provide therapy machines for the Department of Radiation Oncology, as current investment is insufficient. The lack of treatment machines hinders clinical research, experimental studies, teaching, and patients' treatment, demoralizing younger colleagues in the department who are to publish to flourish. Three, the Federal Ministry of Health should enhance its National Cancer Health Program to be effective, and the National Institute of Cancer Research gently improve diagnostic facilities in teaching hospitals, including well-equipped laboratories. The current efforts to subsidize cancer drugs for accessible patients such as HIV are commendable but need improvement. The National Health Insurance Scheme should incorporate cancer management to reduce economic burden on families. The federal government should install, as a matter of urgency, therapy machines in all teaching hospitals, then a lean accelerator potentially funded through public-private partnership. For example, WHO recommends one teletherapy machine to every 250,000 people, which means a country like Nigeria, with a population of 200 million, should have at least 7 as today. The country has only 10, with 5 functioning. This has created unnecessary bottlenecks for our patients. State government should please invest in cancer management, as Kano State government has done. Finally, individuals should please improve their health behaviors, encourage regular checkups, incorporate physical moderate alcohol intake, avoid cigarette smoking, sedentary lifestyle should be avoided, obesity development, and promote healthier lifestyle. Acknowledgements. I'd like to thank my teachers. Acknowledgements. I'd like to thank my teachers, past and present, my colleagues in the Department of Radiation Oncology. They have in several ways enhanced my journey towards success. The late Professor S.B. lecturer in radiation oncology introduced me to the then Dr. Campbell, now Professor Obi Campbell. I thank my former classmate, Dr. Uyishegun, who one day received me and encouraged me to stay on. I want to use the opportunity to thank my supervisors, Professor Obi Campbell, Professor K.K. Ketiku, Professor F. Simieti. I must mention my mentor, Professor Olai Goshiyawo, whom I describe as my academic mother, who painstakingly tutored me on research and publication. I don't have time to tell you what she took me through. I'd like to appreciate my teachers at Memorial Hospital, Bombay, late Professor Dinshaw and Shian Shivastava for their tutelage and support during my stay in India. I want to appreciate my wonderful teacher, University of California, late Professor Rod Withers, a renowned radiation oncologist and radiobiologist. He made my stay able. I want to thank my dean, my former dean, Professor Temidayo Ogundiran, now Provost of the College of Medicine. I thank you. Now Provost of the College of Medicine. I thank you. And also want to thank my present dean, a wonderful guy, Professor Taiwo Lawal. I thank you. Your advice and support over the years are well appreciated. The support of my class of 72 to 78, highly appreciated. Christ School, Ibadan Alumni Association, friends in Christ School, I know some of you are in the hall. The role played by Professor Ile Somi and Professor Adewale, well appreciated. My mentees who are their residents in the department, many of them now are big boys and girls. At least 3 of them are professors, full professors, radiographers, and also the medical physicists and radiographers. Without the medical physicists and radiographers, without the medical physicists and therapy radiographers, we cannot practice radiation oncology. They are so important. I also like to mention and thank our head now. These nurses are special nurses, full of empathy, compassionate. To other members of the department, local organizing committee of this lecture, ably led by my acting HOD, Dr. Folashire, I want to say thank you. And for those who are the editorial committee members, Akinlade, Gmo, I'm humbled by your great commitments. Professor Bumi Olaopa, thank you for finding time to read. Of the director of UI Publishing Press for painstaking a draft. My appreciation goes to my spiritual fathers, there are many. Because of space. I want to thank all of you for your space. I want to thank all of you for your prayers all over the years. My wonderful prayers all over the years. My wonderful prayer warriors in Jesus' house. Our prayer warriors in Jesus' house are wonderful. Pastors in Province 12 are wonderful. Pastors in Province 12, you are wonderful. Members, you are wonderful. Members of the board of Redeemed Health Center, you are wonderful. Members of the board of Central Health, RCCG Mission, I love you all. I want to mention my elder brother, A.A Adenipekun, Aleki of Ileki, and his Odori. I thank you for your support over the years. My siblings, you are wonderful. Thank you for your support. I appreciate the Shokwe Jews, and I thank you. To my